My name is Michael Brettauer, and I'm the co-host of this session. So the next speaker, and it's my great pleasure to introduce her, is Aasma Shaukat. Aasma is the chief of GI at the Minneapolis VA and the professor of medicine at the University of Minnesota, and she will address how to optimize endoscopy service during and after COVID-19. Please, Aasma.
Thank you very much. Thank you, Evelyn and Michael, for this excellent program, and Ernst for his leadership, not just for the WEO, for being a global leader in leading us through this. One thing I think the pandemic has taught us is that we're more similar than dissimilar. And I'm going to be centering my talk around how do we optimize endoscopy efficiency and flow during and after COVID, because our challenges are very similar. So thank you, Jill and Michael. So Stephen already touched upon this. Everybody is very familiar that there's been a worldwide decline in endoscopic procedures pretty much since COVID, and it's affected colon cancer screening disproportionately. This is some of the data that Stephen already covered. In UK, for instance, endoscopic activity was reduced by 95% from about 35,000 a week to 1,700 starting in April. A survey of North American Alliance reported 67% practices operating at less than 10% capacity since March. And below here is a graph from a report from 190 hospitals across 39 healthcare systems in the US, across 23 states, showing that colon cancer screening, primarily by colonoscopy, declined by 86% in March. And you can see that precipitous decline there. So no doubt, this is a very challenging situation. My talk is going to be centered around principles that we could apply and providing a framework for resumption of endoscopic procedures. And it's centered around these themes. We need to be thinking about protecting patients, protecting staff, developing a priority system for procedures, pre-procedure triage and testing, our endoscopy flow, and what we should be doing after endoscopy. So let's tackle these one at a time. Protecting patients and staff. The framework around protecting patients is we are challenged by limited appointments, limited waiting room time as well as space, limited entry into medical centers for patients only, excluding their family members, universal masking requiring universal masking for patients, symptom check and temperature checks at entry, which can lead to pretty long delays and staggered appointments, and also creating hot and cold zones in the medical facility, and then pre-procedure testing for AGP. Protecting staff is centered around providing PPE. Face shields and masks are universal throughout medical facilities, but particularly for endoscopy areas requiring N95s and enhanced PPE, developing newer education and protocols and administering that to the staff and widely disseminating them, thorough cleaning of rooms in the endoscopy suite between procedures, and then learning about enhanced air exchange in endoscopy rooms. This is a graph from a CDC publication, which looks at air exchanges over time and time required to remove 99% of airborne illnesses. We don't know much about COVID, so this is primarily based on airborne illnesses such as TB. But you can see that the air exchange control needs to be optimized so that the turnover time is not prolonged, because with slower air exchange, that time can be as long as up to an hour to 2 hours, which would be tremendously delaying our procedure efficiency. The next step is prioritizing endoscopic procedures. And this is a framework. I believe every practice has come up with its own priority system. So this is a rough guideline that we've used across the VA and most of the US. But essentially prioritizing the indication for endoscopic procedures into different priorities and continuing to offer at least priority ones which would be overt GI hemorrhages, cholangitis, suspected malignancies, and other emergencies. And then thinking how we can introduce priorities 2, 3, and eventually 4. So truly, the pre-procedure testing is where a lot of energy and work has been put in, and it's been a moving target. There are 2 or 3 things that it hinges on. One is the community prevalence of the disease, whether that's low or high in the community that an endoscopy center is at. And then there's a fine balance between how much pre-procedure testing can be done for aerosol-generated procedures and the ability to screen individuals with COVID testing and symptom screen and not having to use enhanced PPE versus not having the ability to do a lot of pre-testing and requiring enhanced PPE, enhanced cleaning and room turnover protocols. So what a typical procedure looks like is a pre-procedure screen 7 days before the procedure, 3 days before the procedure, and 1 day prior to the procedure, where a detailed symptom screen is administered, accompanied with possibly a COVID testing 1 to 3 days prior to the procedure. The ideal thing would be a rapid COVID test the day of the procedure, but that's not always feasible. And symptom screen the day off, again, right before the procedure, before deciding to go ahead with the aerosol generating procedure. And here you can already see that there's a lot of need for extra staff and also IT solutions such as automated text or secure messages that could be administered, and perhaps it doesn't require a manual phone call. And then thinking about the endoscopy flow map, every practice has had to map out what their endoscopy flow looks like. And the idea is that it should be a linear flow where people enter and leave through a different door, and there's no mixing or cross-contamination. So it starts with the waiting room, followed by the pre-procedure area, procedure recovery, and ideally a different exit to the lobby and exit to the facility. We've had to look at our lobby flow map, and what it looked like was things that you see in green for the most part. After the challenges with COVID, what we've had to do is the boxes that you see in blue, where there's all these additional steps of symptom screen at arrival, symptom screen at check-in, waiting in overflow areas since our waiting room capacities had to be declined, and then having the patient or their family member wait in the car or in the overflow area just not to crowd the endoscopy area. So this is, for instance, what our waiting room looks like. As you can see, that our waiting room, which had chairs all across the walls, now only has 2 chairs, and they're at least 6 to 8 feet apart. So that required us to be creative. And the second picture shows the hallway outside the endoscopy area, where we've started to put chairs as an overflow area in order to separate patients. Now, other considerations for endoscopy efficiency can pretty much be summarized in 3 categories. There's been need for extra staff, which is nursing staff for these pre-procedure phone calls, patient education, arranging the testing, and then extra need for techs for deeper room cleaning, and then the follow-up phone calls in 7 to 14 days after the procedure. The other challenge has been extra space, waiting areas, rapid testing areas, storage for all the PPE for the staff, and then extra bathrooms, again, to avoid cross-contamination. And then extra time. Symptom screen takes a lot of time, particularly with the population in the VA that we deal with, which tends to be very elderly. There's added consent to the consent of the procedure. The room turnover time has to be taken into consideration. Every room needs terminal cleaning, which requires time. And then some detailed instructions in the recovery room about symptom monitoring and reporting. And then the follow-up in 7 to 14 days after the procedure all require extra time and add burden. So how have the efforts of resumption of endoscopy been worldwide? This is a survey from North America of 123 GI practices, 55% ambulatory surgical centers, and 45% hospital-based. They reported a 90% decrease in endoscopy volume, with resumption in a median of about 55 days. already 3% centers are at 100% capacity, but you can see the wide majority of centers are at between 25 to 49% capacity. Pre-procedure testing has been planned by about half the practices, and about half will use N95s even if the test is negative. And the practices, in terms of identifying barriers to increasing volume, limited COVID testing capacity was the largest barrier, followed by reluctant patients not willing to come in for elective and sometimes urgent procedures, and limited PPE. And this theme seems to be universal, not just in the US, but across the world. The German experience, this was a survey from 676 endoscopy units administered between April 1 and 7. And here you see a very similar picture. Majority of the practices report being at about less than 40% capacity, and the second most common volume was 60% or higher. 91% identified patients at risk in a structured manner before their procedure, and being able to separate patients at risk, 20% reported complete separation, but the majority said they were only able to do it partially. And routine swabs, testing of personnel and patients, as you can see, is quite low. So in summary, we can break down the time frame into the pandemic, the early recovery, which we're in, and the post-pandemic as we look at it. And there's considerations for the unit, the procedures, and the protections. And currently, the early recovery phase that we're in requires us to essentially evaluate our real estate, the staff burden, and think about newer indications, stratified infection control protocols, stratified PPE if possible, and telephone screening to the extent that we can. And this is my last slide, which is we should be thinking post-pandemic workflow in terms of these 5 S's, which is stratifying, prioritizing procedures, and which patient, which procedure, which endoscopist, being able to screen patients either through enhanced symptom screening or swabs or a combination, being able to separate patients, creating hot and cold zones, whether it's flow around the hospitals or time of the day, which scopes we're going to conduct and how, and then being able to survey and follow up patients, checking for infection days 7 and 14, and clinical follow-up and reporting, and being able to, again, modify our protocols based on our findings. So ladies and gentlemen, this is truly the new era we're in, and I believe we're all in this together. And around this framework is truly how we need to be thinking and approaching endoscopy. So as we go forward, the punchline seems to be keep calm, keep safe, and scope on. As the other speakers said, we must continue with our endoscopy, but our new reality is enhanced PPE and several enhanced protocols. So it's challenging, but it's still doable. And I believe we're ready to rise to the challenge. Thank you.
Thank you so much, Aasma. That was really interesting. We have time for one question, and I will relay what is on the board here in the question and answer section of this Zoom talk. And Stephen, you may chime in because this is also about your topic. So in the future, and Stephen has elaborated on that, in some countries, or in many countries, I should say, here in Europe, there's an increasing a surge of COVID-19. So Aasma and Stephen, in your opinion, what is the major barriers for continuing to provide endoscopy service, or even coming back to the level that we had before? Is it about organizing our patient flow, as you so nicely have lined out for us, or is it about patient fear, anxiety, that don't want to come in, so poor compliance for screening? Or is it that we don't have the staff because the staff needs to help out for COVID patients? What are like the challenges that we are going to face in the next months to come?
Yeah, I'll go first. Thank you, Michael. I think you nailed it on the head. It's those three categories. And I feel like with every healthcare system, the priority of those three challenges is slightly different. So staff and PPE, patients being fearful, and then increased demand and requirements for extra time. In the US, we're certainly not seeing a decrease in demand from patients wanting to schedule their procedures. But here, the limitation seems to be the PPE and testing prior to the procedure, particularly in the higher prevalence areas. So I'd say those are the larger barriers.
I think from my perspective, the primary consideration is just the resource available to provide the colonoscopy. We just don't have sufficient colonoscopy. It's become quite clear that in a number of countries, there is a fear at this point in time, A, to do the screening with FIT, and even more so in doing colonoscopy. Now, how that will roll out over time, it's difficult to tell. I think the other challenge that we've got is deciding what we wish to do in terms of the backlog. Do we wish to clear those ones that have accumulated during a period of shutdown, or do we wish the screening program to be able to return to what it was with the timing of the invitations as they would have been if COVID had never occurred? And that requires us a very substantial increase in colonoscopy resource for a short period of time. And few countries would be able to muster that level of support.
Thank you. Thanks again, Aasma.